Well, good morning.
Good morning.
Welcome. Great to see such a full room. Welcome to the Follette Health Policy Forum breakout session on health coverage and access. Thanks so much to Lisa and the Follette School for putting on this really great event. My name is Stumm. I'm the editor of Wisconsin Health News. I'm going to serve as the moderator for today's panel. We have a wonderful lineup of panelists with us today. To my left is Dr. Tito Izard. He is a physician and the president and CEO of Milwaukee Health Services. Next to him is Kirsten Johnson. She is a health officer and the director of the Washington and Ozaukee Public Health Departments. Keeys is the director of health equity policy and advocacy for the American Medical Association. And last but not least, Gwyn is a lecturer with the Department of Economics at UW-Madison. So as I said, as I mentioned, this breakout session is focused on healthcare coverage and access. The state of Wisconsin has maintained one of the lowest uninsured rates in the nation, and yet many in our state lack affordable access to healthcare services. So today's panel will discuss strategies to increase patient knowledge and improve access. This is an interactive event, so they have some introductory remarks lined up. I have a series of questions to start things off, but then we are going to leave some time at the end for audience questions. So we are going to start with each panelist just taking a couple minutes to highlight what they see as the most important things to consider when we talk about healthcare coverage and access. And so I'm going to start with Dr. Izard, and then we're going to work our way down.
All right. Well, make sure that everybody can hear. Can everybody hear okay? All right. Well, it's great to see so many people on the early Monday morning, so I'm really excited about this topic, and thanks to Tim and to the panelists. I want to start off in this discussion. If we look at Wisconsin as being one of the lowest uninsured rates in the nation, according to the Agency for Healthcare Research and Quality, the disparity between white outcomes and Black, Hispanic, and Asian outcomes is one of the worst in this country. In order to fully grasp the complexity of disparities and health equity amongst underrepresented minority populations, one must caution the ethnocentric examination of these differences by classifying them due to similar causes. In Milwaukee, the largest city of the state, Blacks comprise nearly 40% of the city's population. It is well understood that race is a social construct, and therefore the definition is meaningless. Its poorly scripted label, Black, is the only form of unity identifying that 35 million Americans historically have had to relate to one another's plight, struggle, and experience. Despite having an ancestral lineage extending back 400 years and preceding the birth of this nation, the Institute of Medicine has identified Black Americans as persistent retainers of the poorest health equity status of all American citizens. The cause of this enigma extends beyond the cursory explanations associated with health aptitude, insurance coverage, and access to quality facilities. Statistically significant health inequities exist for Blacks, particularly those with lineage extending from the institution of slavery, irrespective of educational attainment, economic status, suburban living, and refraining from detrimental health behaviors. In an article from the Wisconsin Medical Journal, it stated, despite an increasingly awareness regarding the social determinants of health, many people still believe that the two main factors to improving health are to reduce unhealthy behaviors and increase access to health care. I will argue against this presupposition. I will argue that the preponderance cause leading to health disparities, such as maternal and infant mortality, are direct consequences of being an American descendant of slavery. American descendants of slavery, I'll refer to as ADOS, name has changed over the years, but the process of being used, exploited, discarded, replaced, and erased has remained. In the book, Medical Apartheid, by Harriet Washington, she describes how Dr. James Marion Sims, affectionately known as the father of modern gynecology, performed 30 surgeries on a 17-year-old slave named Anarcha without anesthesia. For the enslaved, doctors were not the altruistic caregiver, but were hired to accompany the plantation slave masters at the slave auctions to examine their chattel, and were called in to treat sick slaves in order to protect the owner's interests. This relationship has never been one established in trust. Even President Thomas Jefferson said, "I consider a woman who brings a child every 2 years as more profitable than the best man on the farm." As human commodities, wealth accumulation occurred through the extraction of their bodies until they became a depreciating asset. Mirza Baradian, author of The Color of Money, described how slaves could be used as assets, debts, credit, or currency. During America's period of wealth consolidation in which blacks were predominantly excluded, the lack of wealth expression by ADOS results in being perpetually trapped in a permanent underclass and reinforces the elusive dream of one day becoming a first-class citizen. Today, 50% of Black Americans have zero to negative wealth and experience the slowest recovery after the Great Recession. Every societal determinant of health for ADOS is directly linked to the lineage of enslavement, failed government protection during Reconstruction and Jim Crow, exclusion from the Homestead Acts, FDR's Social Security, VA, and Federal Housing Administration loans, which established America's middle class, the development of peonage and convict leasing, unequal justification and redlining, subprime mortgages, and mass incarceration. Data from the 2016 National Survey of Children's Health shows children of different races and ethnicities do not experience adverse childhood experiences equally. Here in the Northeast region, which Wisconsin lies, Black children who experience 2 or more ACEs experience 38% versus 19% for whites, 22% for Hispanics, and 9% for Asians. According to Morrissey and Rothstein in the May 2019 Economic Policy Institute report, Toxic Stress and Children's Outcomes, African American children grew up poor experience more toxic stress, which can impede the child's behavior, cognitive capacity, and emotional and physical health. These African American and social and economically disadvantaged children also have less access to protective resources that can mitigate their stress to tolerable levels. Now is the time to go beyond diversity and inclusion. It is time to embrace a restorative health equity plan. Without wealth, American descendants of slavery are unstable. Innovative approaches to addressing refractory to care patients will require healthcare practices to better understand the direct correlation between instability and how it creates dissociative behaviors disproportionately among disadvantaged and vulnerable populations. Thank you.
Great. Thank you, Dr. Izard. Kirsten.
Thank you. Thanks for having me. It's a pleasure to be here. And interesting that I'm going right after you. So I am from Washington and Ozaukee counties, the two healthiest counties in the state of Wisconsin. And I would argue that the health status in our counties are because we are wealthy. And it's because of the historical context and the historical policies that have been put in place to assure that those populations remain healthy in Wisconsin and elsewhere in the country. So my premise is that the health system is much broader than healthcare. Our Medicaid enrollment numbers are around 5% for Ozaukee County and 7% for Washington County. And although we have very high level of access to care, we simply are lacking Medicaid providers in our counties, so we often send people to Milwaukee for care. In addition, as Dr. Izard said, one of my beliefs is that we need to look at investing in humans and investing in human capital, because unless we look at economic development, we will never raise the bar on health across Wisconsin. And the way we talk about social determinants of health, I'm concerned that we are medicalizing them, asking who's going to pay for them. So I think we need to change or think critically about the questions we ask when we're talking about healthcare access, and then change the rules so that everyone, particularly people of color who've been historically disenfranchised and deliberately put in those positions, are brought up and invested in so that they have equal access to health.
Great, thanks. Mia.
Thank you again also for bringing me here. So I speak on behalf of the Center for Health Equity of the American Medical Association. And for many of you who might know a bit about the history of the AMA, we've not always been on the right side of history when we're talking about, no, not at all. That's okay. That's okay to laugh. It's, sometimes you laugh to keep from crying because it is real. We're a 175-year-old organization, and it's only within the last decade or so where the AMA has really started to come forward and talk about issues having to do with inequities and disparities, right? So that is something that I always lead with because even physicians who historically maintain this trusted voice, physicians and specifically the AMA are considered to be the trusted voices of America, but we're still very new and young when we're talking about issues having to do with avoidable differences in health outcomes. Right, so I say all that to say, in terms of talking about expanding access, when we're talking, and I want to be very clear, by the way, we're going to spend a lot of time together later on. I hope you all are going to be here at 3 o'clock. So I'm actually going to keep my comments a little short, but I do just want to harken back to what Dr. Altman was talking about earlier in that we're no longer necessarily talking, the conversation isn't as much around coverage, although we really need to have the more narrow conversation about whose voices and whose lives the data suppress, right? That 8% that was on that pie chart, like who are those people who were left out of the coverage gap? But really also just understanding that historically, even with access, that doesn't necessarily determine high quality care. It doesn't determine that one will be compliant with respect to their medical care regime. And it also doesn't determine that physicians or care providers are going to be really very understanding or considerate of the non-clinical issues that bring their patient to them to begin with, right? So then people in the pipeline and medical schools are not trained to deal with culturally competent issues consistently or anything like that. They're not trained to recognize stresses that are associated with racism or genderism or poverty in such a way that they can take out their prescription notebook and write something in chicken scratch, and someone can take it to the nearby pharmacy and say, okay, cure me of this inequity. And so right now, that is where the Center for Health Equity at AMA is coming in, looking at other more upstream interventions with respect to policy, with respect to non-clinical innovations outside of the care setting, with respect to using augmented intelligence to close care gaps, and certainly gaps with respect to coverage, and looking in spaces that are rural, and looking at ways to really fill gaps with those innovations. So I will stop there, and I look forward to having deeper conversation with us here and certainly later.
Great, thank you. Gwyn.
Hi, I come as a researcher and not necessarily as somebody on the ground, so I'm going to try to bring a researcher's perspective to this. But I thought what I could contribute then is to kind of give a broad overview of what Medicaid is like in Wisconsin, and then how we measure access to care and the relationship between coverage and access. So Wisconsin is a pretty unique state because we are a non-expansion state. And so what I mean by that is that anybody who is less than 100% of the poverty line, including childless adults, which is the really unique aspect here, can qualify for Medicaid. Of course, there's other ways you can qualify, but I'll use the income thresholds just because they kind of drive the point home. And so what that means then is that for Wisconsin, you can either qualify for Medicaid or you can qualify for subsidies on the marketplace. And so we don't have that coverage gap. So it's kind of looking at states near us, and the closest state to us that hasn't expanded is Missouri. So to put this in context, if you lived in Missouri and you were a parent and made less than 21% of the poverty line, you would qualify for Medicaid. If you're a childless adult, you don't qualify at all. And so what that means then is that Missouri has this gap where people between 22 and 100 or 0 and 100, depending on your children, wouldn't qualify for Medicaid and wouldn't qualify for subsidies on the marketplace. And so we're kind of in this unique position. I think broadly that's one of the reasons. Of course, there's many economic factors driving our low uninsured rate, but certainly that's helping. To put it in context, in Wisconsin, we see about 5.5% uninsurance rate. But to illustrate some of the disparities that we're seeing, for white individuals in Wisconsin, it's only 4.6%, whereas for Black or African Americans, it's almost 8%. And for Native Americans or Alaskan Natives, it's close to 19%. So you see this pretty strong gradient. And you can look at it by income or education as well, and you'll see the same thing. Since the passage of the ACA, as you might imagine, there's been a plethora of research about how states that expanded differ or are the same compared to states that didn't expand. First, people would look at coverage, and of course, expansion is tied to coverage, but then secondary outcomes like access to care, and I don't mean secondary as in they're less important, just the next step here. And so broadly speaking, what we find is that comparing states that expanded to states that didn't, the states that expanded Medicaid tend to have better access measures. From a researcher's perspective, we're really looking for something that we can identify in the data. And so it might not be perfect. I think Dr. Altman illuminated this point. But typically we would use whether or not you've had an appointment in the past year or whether or not you have usual source of care. I should say, though, that it wouldn't be uncommon for researchers to look at whether or not you've foregone care because you couldn't afford it as a measure of access as well. So thinking about those other financial outcomes that you might be interested in are not uncommon to look at in the literature. Overall, it looks like states that expanded have better access measures. But I should give two caveats to that. The first is that papers that came out or research that came out very early on didn't find a lot of movement in access. And I think this really highlights the fact that this is a sticky problem. This isn't something that changes overnight, that we can insure everybody and all of a sudden we have access to care. It's a complicated and complex system. And then the second thing that I'd maybe like to talk about or think about a little bit is that because Wisconsin is in this unique position where we don't have that coverage gap, we really want to focus then on studies that look at people in this narrow poverty bin between 100 and 138%, and that's a little bit unique, harder to identify essentially. And then I think we'll talk on this a bit during the panel, so maybe I'll just highlight that the state is implementing and trying a few different programs to expand access to care. So the governor, for example, has a task force on prescription drug pricing, and this is meant to think about just creative ways that we can lower drug costs. I think you see this in the federal government as well, something that's being talked and thought about a lot. There's different pilot programs aimed at testing ways to improve access, and here the state and states in general have some flexibility in how they administer Medicaid. And so you can imagine pulling a lever and seeing what works and what doesn't when we try to improve access. And then, yeah, I'm looking forward to talking about all of these points in a little bit more detail as we go through the panel.
Excellent. Well, thank you guys so much. A lot of excellent points brought up. A topic that was really kind of mentioned by everyone, and I'm going to skip right to questions on that, is health equity. More specifically, the health inequities that we face in Wisconsin. I think most people in the room have seen some of the grim stats for our state. In the University of Wisconsin Population Health Institute's latest report, they gave Wisconsin a D for its health disparities. Black babies in Wisconsin are 3 times less likely to reach their first birthday than white babies. Depending on what part of the city of Milwaukee you live in, your life expectancy can fluctuate by decades. Dr. Izard, I want to start with you. And you kind of touched on this in your introductory remarks. Could you just expound a little bit on how these disparities, specifically in Milwaukee, are impacting overall health outcomes, and how much of this is due to access issues?
Access issues, right. So just the fact that it's predominantly a southeastern Wisconsin issue needs to be recognized and identified because it just didn't happen that way in the first place, right? So even a black child and I'll speak in general of black, because you heard me mention about black versus American descendants of slavery. If you go back to 1980 or so, about 97% of blacks in America had lineage to slavery. And with the expansion through what we call the black diaspora, which is someone who might have been from the Caribbean or from the continent of Africa, through immigration, that number now is roughly around, close to about 80% would be those that have lineage, and close to 20% will have some relationship to immigration. So in the conversations, I think one of the important things that we need to do is, even in our science and studies, we never really truly recognize the differences that exist. So I think we need to be able to tease that out. But when we look at access to healthcare, in the city of Milwaukee, you can drive, well, as we know, Milwaukee is roughly around 600,000 people in the city of Milwaukee, and you can drive all the way from downtown until you hit Ozaukee County and not hit a single hospital, because you're driving essentially through the central city or the north part of Milwaukee. So the significant condensation of black people in the central city, and then the absence of medical practices, clinical practices, as well as health systems, is pretty significant. And of course, we all know that is predominantly an economically driven issue. At least that's what people tell us. But that's why the solution really does have to address the economics.
And can you, and I'll just stick with you with a follow-up question, but can you just expound a little bit on, what are some of these potential solutions to at least trying to tackle some of this?
Yeah, I think, as I mentioned, looking at a comprehensive health equity. So we talk in terms of health equity, and it's extremely important that when we have these conversations that we don't lump all people of color together or all minorities together, because sometimes the reasons that are contributing may vary and differ. For example, I still haven't seen a lot of, as I mentioned, as far as looking at being able to tease out the differences between African American that has lineage versus someone who is either first generation or so. We do see that in our infant mortality statistics, that someone who's an immigrant, a black who immigrates to the United States, actually doesn't have the same infant mortality outcomes as American blacks, but the longer they're here, it does change. Another thing that we don't see in our studies, we kind of lump the Hispanic or Latino community together and look at some of the numbers, but we really don't tease out to say, looking at the Latinx community based upon the number of years they've been here in the contiguous state here, versus whether they're in Mexico or Puerto Rico, and to see if some of those immigration-related issues will that impact or affect on the different health outcomes. I think those things will help us have a better understanding. Also, what we've historically done is talk about income historically in our data research. We have not looked at the impact of wealth on some of these poor health outcomes and access issues. And that's more in the last 10 to 15 years where we've really been able to look at the wealth data and be able to identify the absence of wealth. So one of the things I try to do in my discussions and conversation is to help people understand that that it's not just an issue of poverty, meaning income. It actually is the wealth position of that individual in the family. So I like to say the expression of wealth is what stabilizes you. And what I mean by that is it's not your income, but it's your wealth position. So if you or your child wants to go to college, it's not what your income is, it's how much money you have as a family. Do you have a home that you can tap into the equity in order to send your child to the college that they want to go to or that they can get admitted to? If you are stopped by the police and you're put in jail and you need to defend yourself, it's not your income that defends you, it's your wealth. Because if you stay in jail long enough, if you don't have enough money, you will lose your job, which means you will lose your income. And therefore, it is what you have in savings. It is your wealth position that allows you to defend yourself. Every single social determinant of health component, again, is linked to that lack of wealth, particularly with African Americans. And then you even think about, the political influence. We know that wealth plays a big role in that. So I think some of the solutions regarding, how, and I'll get a little bit further into it a little bit later, but what we're looking at is restorative health equity. Is one thing to say, stop doing an insult on a person. That's great and wonderful. But it's another thing to say, once you stop the insult, if you still have to bring that person back to where they were, and to actually move them along the pathway so that they're in an environment where they now can compete based upon merit.
Excellent. Some have suggested the idea of a universal basic income, just something to kind of get more into a place where they could afford some of this stuff and eliminate at least some of this chronic stress that experts have said can lead to a lot of these negative health outcomes. What are your thoughts on that? Is that something that can be perceived as a potential solution?
Well, I think some of those things are worth looking at, but I think it's been misled in some of the political conversations of trying to have that be a solution. Dr. King, most people aren't even aware that Dr. Martin Luther King Jr. actually discussed this universal basic income back in the 60s. And so you have someone like Dr. King, but then you even also have Milton Friedman actually talk about it and say, these are some potential things. But the time of where we were as a country and where wealth, in the distribution of wealth for low income to high income wasn't as significant as it is. Personally, I would need to see some really good research that would show how that would matter. If everyone received $10,000, all you did is the distribution, everybody moves up to that same degree. And we all know the potential with inflation potentially, that the cost of housing, the cost of cars, the cost of milk, everything potentially could go up, and therefore your $10,000 may not necessarily go as far. So I don't think that you can do any type of all-American plan until you actually put specifically in place a comprehensive reparations plan for American descendants of slavery that would specifically address that insult, and then now, based upon where people are after that, be able to make determinations.
Mia, you're really a national expert on this issue. This is, in Wisconsin, an issue that is most intense in the Milwaukee southeast corner of the state, but this is a national issue, obviously, and in pockets across the country. Nationally, what are some of the potential solutions that are being looked at and analyzed?
So I wanted to pick up on what you were saying, Dr. Izard, in terms of UBI. And so from an AMA perspective.
And can you just spell out the acronym?
UBI.
Oh, Universal Basic Income.
Yeah, sorry.
Thank you. I'm sorry. I will not speak in acronyms for the rest of the day.
It's a challenge.
Well, except for when I say AMA, you have to.
We'll let that one go.
Yeah, for sure. But I agree with what you're saying. Essentially, UBI stands on a platform of equality, right? Equality is not the same as equity, right? When you're talking about equality, everyone gets the same thing. There's no difference, and therefore there's no recognition of different experience, which frankly is a perpetuation of the same insult that or social insults to which you're referring. When we're talking about equity, we're talking about first and foremost recognizing that we all start at different playing fields, right? I had dinner with some lovely students last night. I don't know if I think they're all working the different forums today, but I told them a story about my younger sister, who is a kindergarten teacher, and we've just come off of Black History Month, and so she and her other kindergarten teacher colleagues were putting on this whole celebratory end of the February Black History Month program, and she received an email from a disgruntled parent who expressed that he felt that she was doing his child a disservice by teaching this this idea that we're all different and that race is something that we should be attuned to. And he really took major issue with her stance to celebrate people of African descent and Black Americans. And so she did not reply right away. I won't share what she did say, but my takeaway from the overall story is that it's not even enough to have the conversation that equity and equality are different. We have to also understand that some people are not even willing to recognize that. And when you're not willing to recognize that we're all starting at someplace different, even if for nothing else than to celebrate a people's, then that's a problem, right? Not only is it a problem, but this man has children, and as a parent, he's now pushing back on an education that is supposed to help rear this person who's only been on the earth for 5 years. Into this new understanding that, hey, it's okay to say little Johnny lives in a different house than Micah. And as a result, and not even as a result, but their housing situations are a result of long time differences in terms of power distribution. That's really what you're getting at. It's wealth, but I think when we talk about wealth, we really have to understand, to your point, that wealth is an expression of power. And power differentials socially will determine consistently whether or not we like it, where our children end up. And so, again, I'm gonna shut up because I have a lot to say later.
Well, just to follow up on that, looking at it from a healthcare perspective, there are a lot of players in the healthcare system. What are some steps that can be taken? What are some potential solutions, and what are the responsibilities of those in healthcare?
I didn't answer the question. What you asked me to do. From a health, looking in again, socially determined factors, up to 80% of them determine our health outcomes, right? That is what research is consistently saying. I'm going to show you a slide later on that says at least 50%, but the range is definitely between 50 and 80%, right? But there are things that clinical settings can do and health systems can do to really help to shape the lives of their patients once they leave their 7-minute appointment, right? For one, there are several hospitals across the nation, especially those that have really big trauma centers and emergency rooms, who are working with community organizers to raise conversations and consciousness around gun violence, right? So having forums within the actual hospital system about why violence is a major health threat, right? And not just a one-off situation where someone is treated and then they're let go. No, if they're let go and back into the same environment from which they initially came, then that's just going to consistently drain the resources of that very system. I used to work for a member of Congress, Robin Kelly, just next door in Illinois, a couple places in Illinois, and she has a number of health systems down in the rural area, and those hospitals have actually built apartment buildings for a number of their patients, some of whom are elderly, others who are experiencing homelessness, and they place them, like they are prescribed housing once they leave. I mean, they have to qualify to receive the housing, but that level of innovation and really that relatively small upfront investment in housing is going to save that health system tons and tons and tons of money. There are other spaces that are prescribing food because they're screening for food insecurity of their patients, right? There are other systems that are really helping to, before the enrollment period starts, engaging their patients or potential patients on street corners, in barbershops, in beauty salons, and really being very thoughtful about going to where the people are. Because again, accessibility is an issue often of people can have a physician, but they may not have transportation to get there. So a lot of hospitals are now partnering with Uber or Lyft to bring their patients to the physician. And of course, they're abiding by all the HIPAA rules and such like that. But that introduces a whole nother element of using augmented intelligence, of using different networks, these non-health related systems that are way, way above, they're moving a lot faster than we are in healthcare with respect to really being innovative and trying to figure out how do we need to look at and interrogate access, where does the onus fall in terms of physicians who need to recognize that beyond the biological body, there are social forces that make or break people's wellness.
Excellent. Kirsten, you started off by talking about how in the UW County Health Rankings annual report, Washington and Ozaukee are always at the top of the list. Milwaukee County is often always near the bottom of the list. Could you talk a little bit about what the role of local health departments can be in addressing health inequities? Milwaukee and Ozaukee share a border. What is departments like yours doing to address stuff like this?
Absolutely. So I think that some of you have probably heard of the model of the Public Health 3.0 and what the role of public health departments are in convening everyone who has an influence on health in communities, which is basically everyone, as you can imagine. But it's interesting in Washington, Ozaukee County because it's two of the most conservative counties in the state, and it's a hard conversation to broach because if you use the wrong language, you get a lot of pushback that there's not going to be investment in public health or investment in those social determinants of health. So we're very cautious about the language we use and how we frame the idea that it's the responsibility of the community to address everyone's health and bring everyone up for more around equity versus equality. And that's a hard sell in both counties. But what I see the role of health departments as is to understand that fundamentally it is our role and to have those conversations one-on-one, to think strategically about policies and how we can address some of these policies, like I mentioned in my opening comments around the medicalization of social determinants of health, I think it is important to address individuals' social determinants. So I applaud HMOs and healthcare organizations who are providing food as prescriptions and housing as a prescription, and it is working. I mean, for people who have chronic disease, we are seeing better health outcomes for those folks. But I also think it's important to think more broadly. So why are they in that position in the first place? How do we assure that there's affordable housing? In Milwaukee, for example, how do we assure that you mentioned it's about your family's wealth and not necessarily income and their ability to get to college. Well, we have a failing public school system. How do we assure that everyone in our community has equal access to those pieces, to education, to affordable housing, to a living wage, we're thinking about coronavirus right now, so having sick time. And there are many, many people in Washington, Ozaukee County, but it affects people in Milwaukee more that don't have access to those things. We're basically assuring that they're going to be unhealthy. So again, how do we take a step back and deliberately dismantle those policies that have been put in place? In my counties in a way that is palatable and that can be embraced by both parties. Yeah.
Excellent. Please, yes.
Coming from Milwaukee and looking at the partnership between public health and communities and as practicing physician in the inner city. In Milwaukee, we still have 70,000 homes that haven't had their lead laterals replaced. Yep. And then we expect the families with very limited incomes will provide them possibly with a filter, a water filter, but then they have to change that out on a regular basis and without an active plan to be able to do that. So things that our public health officials and commissioners can, at least in Milwaukee, as a part of the cabinet. I'm not sure if that applies in every county and every community, but for the most part, being able to make sure that these environmental factors are being addressed with a specific plan and not just talking about it. So for us, right now in Milwaukee, we didn't even get 1,000 done within a year. And so, how long will it actually take before we just replace that? Now, I know in Madison, you guys were able to do it pretty quickly.
I just want to add to that. So that when I mentioned investment, I think that's part of it, is being able to sell the investment that we have to invest in these communities and we have to invest in people's health. Mm-hmm. So the lateral lead lines. And I could just speak to the lead piece in Milwaukee that they are giving out you get a free attachment to your water filter. It's good for a month or two, and then guess what? So I think again, it's really about thinking very strategically about how do we have the funds to invest in these communities, and who is responsible to pay for those things. But it's a failure of our systems and policies that this is happening.
I think, and the health commissioners can help our communities have that conversation on, what are our abilities, what are our desires, what are our commitments. But in the end, the only thing that really matters is what are we willing to sacrifice in order to make it happen. And if each community isn't really willing to truly discuss the sacrifice necessary to overcome, what ends up happening is you get the pervasive malignant indifference that happens in people. It's not as so much an issue of straight out racism as it is malignant indifference, meaning that people stand on the sidelines, and because it's not directly impacting on them, they're not responding or acting in a manner to help out others until it comes into their backyard. And so in the communities such as, Ozaukee or, River Hills or North Shore or anywhere, and being able to have these conversations, what is this community willing to sacrifice a little so that we can advance some of these issues?
I want to just jump in here and go back to what you said earlier, Dr. Izard, about using a restorative equity framework to really hone in on these conversations. A lot of the major tension between public health policy and actual physical medicine comes down to the speaking of different languages, right? And not only the speaking of different languages, but really wanting something different in terms of the overall outcome. So the thing that I think a lot of us forget about an equity framework, it's not just something that feels good and we should all hop on the equity train because it's a moral imperative. It's actually a really effective and efficient strategy in terms of truly moving systems toward greater compromise, right? So if you can use the equity argument, right? So within the equity argument, there are points about how much money it costs to not replace these or tear down these homes in terms of workforce hours lost because people are sick, in terms of people really being a part, really having to depend on public benefits and that kind of thing. So that is an equity argument, right? And really helping to frame the conversation in such a way that more conservative physicians, or even, and I'm saying conservative specifically because, and this is not a jab at people with more conservative politics. It's just that historically, when we're talking about disparities, when we're talking about equity, these are conversations that the so-called liberal parties have been having for a long time, and that doesn't mean that they're even better at explaining differences. It just means that they're just more practiced in using the word. But if you can say to someone, not doing X is costing you Y, then you've made another partner, right? And that's where the tension has to really be broken apart. Helping to use the equity lens to identify language that is cross-cutting in terms of political party lines, in terms of where you get in, whether it's in an actual hospital, on the grounds working with people in public health settings, or if you're in a policy or some type of planning forum, using equity as an efficient driver to common language.
Gwyn, did you want to add to that?
Yeah, I would like to add a little bit. So I think on the research side, we're thinking about that as well. There's some papers looking at, or some ideas looking at, if you had health insurance, for example, during childhood, what happens to you later on? And so trying to actually quantify that in terms of taxes paid, or again, talking about receipt of other welfare benefits. It looks like Medicaid for children almost pays for itself, just in terms of taxes and welfare, changes in welfare receipt later in life. And so, part of the problem is that takes a lot of time to have this 30-year look-back window, but I think we're starting to do a better job of that and thinking about everything in terms of an entire life cycle. So what happens to you when you're a child actually has long-term consequences that we can think about.
And just to let you know, even studies have shown, even a black child that's adopted into a white family, it's actually the mother's health that impacts that child. So black children adopted in a white family still have higher mortality rates in that first year of life.
Kirsten, shifting gears just a little bit, what are some of the more targeted, kind of more focused approaches that you're doing in the counties and in the region to address and improve access to care?
It's a good question. So access to care in terms of actually getting people to the care they need in the health department setting, we do a lot of case management. So we have WIC, so Women, Infant, and Children nutrition program. That's primarily how we have families enter our doors, and we literally call providers to make sure people have access. I mean, my nursing staff, that's how they spend the lion's share of their work day, is getting people into providers. And in our communities, particularly around dental, is a huge issue for us. More broadly, and this is a whole other conversation, but we work very closely with our hospital systems, and they are now required since the ACA to report their contribution to the community to remain a nonprofit hospital system. So I see our role as in public health as well is to really push them out of their comfort zone. Instead of claiming so many dollars and hours spent providing care, to think, how do they invest more strategically in our community to assure that we don't have these disparities?
Dr. Izard, at Milwaukee Health Services, which is a federally qualified health center in Milwaukee, what are some of the innovative approaches you guys are taking to increase access to care, or some of the more targeted approaches that you've taken that seem to be working so far?
Yeah, I think one of the best things that improves access to care, one of the things that we implemented was to, and our organization is primary care, so family, internal medicine, women's health, which include midwives, OB-GYN, internal medicine, pediatrics, podiatry, dental, behavioral health, as well as on-site pharmacy and other services. So it's a very comprehensive practice, and our statement is 80% of our patients will be seen within 24 to 48 hours. Now, sometimes it may be 48 hours because of transportation, if they have to call and schedule that in advance. But for the most part, our goal is to ensure that a person, for us, access, we define access as timely, appropriate, and as cost conscious. And so, and ensure that someone comes in when they need to come in, we set that as part of one of our goals. But one of the best things that improves access to care is actually that relationship with that healthcare provider, and not just the provider, but the healthcare team. And this is where the issue of social capital really plays a significant role, and it's probably poorly understood and poorly researched to truly see how that influences on improving access to care, reducing no-show rates. Typical inner cities, no matter where you are, throughout the United States will have somewhere around 40% no-show rates. And that's a huge barrier to access. Because what it does, it takes that provider, it blocks their schedule if someone doesn't come, and someone could have actually come in that place. So when you look at practices that have the highest no-show rates, and you'll find that those practices typically have high provider turnout, lower cultural, compassionate customer service, which that's what I refer to as, and those factors. So it influences or interferes with building that strong relationship. But when you have staff who've been there a long time, they can contact the patients, they call them. If they didn't show up, being able to do those follow-up calls, those little bit of differences makes the difference for that person coming back. And then you can find out, well, what were some of those barriers, and then you start addressing those barriers. Other things that we do is, as a community health center, we make it really clear, and all the fairly qualified health centers try to do this, is to make sure we do activities for the whole community, not just for our patients. So by doing that, we're actually assisting people in the whole neighborhood, and so that message spreads around to other people, and people are more likely to come and gain access for needs.
Mia, I don't want to steal too much from your afternoon keynote. I know you're going to talk a lot about AI and that, but can you just talk a little bit about the role that technology can play in helping improve access to care?
I wrote a nice little paragraph to read. Mostly because I get so passionate about this issue, and I don't want to lose my place. So do forgive me, because I am going to read directly from this paper, okay? But when I say AI, I'm talking augmented intelligence, right, as opposed to artificial intelligence. And there's a whole literature that essentially lays out the difference, but at least from the AMA's perspective, we're talking about using clinical enhancement decision-making tools, So that's why we talk about augmentation rather than artificial intelligence. So for me, the main questions really just come down to the mechanics of algorithmic bias and man-made algorithms to the extent that they actually achieve objectivity, right? So that's really, and another question that's also important to me is, would it actually be appropriate and effective to have a proxy measure to help physicians make better, or to make decisions, and would those decisions then be better than if the physician had never used that clinical enhancement tool to begin with? And overall, in terms of using technology to advance an equity agenda, we have to be really, we have to interrogate key assumptions that are built into algorithms. Predictions of actual measures of wellness may lend greater utility than systems that don't use it. Really quickly, has anyone ever heard of Optum, the health system? Yes? Okay, so I see a number of hands up here. So Optum is a health system out of New York. Recently, over the last year, there was this huge study that came out that essentially showed that Optum had put out this clinical enhancement decision-making tool for physicians, and what they would do, what they were doing was essentially stratifying their patient body by who was most sick compared to who was less sick, right? And the proxy by which they stratified the body was how much, or the patient body, how much, not the actual body, the actual pool of patients is the more concrete term to use. They were looking at how much people spent in the healthcare encounters and all together, and if they spent more, then those people were deemed to be sicker, right? If they spent less, then they were less sick. And this was the proxy that they used to determine who should receive better care. Now, someone shout out to me why that's problematic. Because if you're talking about a society that's also racially stratified, people who spend more tend to be more well off, and they have greater access to care because they've got maybe more comprehensive health insurance. They don't have these social barriers that keep them from presenting for consistent care and such like that. And those who spend less for myriad reasons, other than maybe they can't get there. Maybe they don't trust necessarily the provider space, and so they don't have a practice of going, right? So that is a problem when you're talking about, okay, this patient is sick, this patient is also sick, but this person spends more money, that means that they are more sick. Let's give them the better care. That's what the system that Optum put forth essentially was doing, and that's a problem. So anyhow, I'll go back to my paragraph. So, a collection of socially determinant factors like socioeconomic status, like zip code, and so on, has demonstrated an improved design of treatment plans for patients with specifically with heart health risks. So that's what Optum was looking at. The system was looking at heart health risks, right? So rather than using a proxy based on economics, although economics is important, it really is also important to narrow that space down and look at zip code, look at other more direct measures of lived experience, and use those data to feed into the algorithms. The other thing we need to make certain that AI systems are doing, augmented intelligence systems are doing in the healthcare system, is before they're even introduced to the systems, the ways in which they're designed, they have to be developed according to guiding principles that are grounded in equity. And those principles have to be inserted into the mechanics of the actual AI algorithms, many of which are developed by, and keep this in mind too, a lot of existing health algorithms are developed by historical data that are widely used across different industries. And that's problematic because those data are not only decades old, oftentimes, but with respect to the healthcare system, they were derived during times of lawful segregation, whether it's de jure or de facto segregation, right? And those are the data that a lot of healthcare systems are dependent on in terms of using these algorithms to teach their machines to help physicians to make better decisions, which isn't a better decision, right? If you're using old data, if you're using data from a completely different time period, then of course the actual output is going to be biased, right? So, and I'm talking about times where government sanctioned redlining. You mentioned redlining, Dr. Izard. I'm going to talk more about redlining later on. These data these are the data upon so many so-called innovative systems actually rely, and it's problematic. So when you're incorporating large data into AI, it's not innovative. Large is not better. Big is not better in this sense. It's really the refined data such that everyone from input to output, the coder is aware of their own bias and how their own bias might really impact the system down the line. The data that the coder or the researcher then uses to help design the machines and such like that, all of that has to be really evaluated quite rigorously in order to make sure that the output isn't something that's harmful not just to one patient but to swaths of patients. I'm actually not going to read the rest of this paragraph because I have a lot of exclamation points, and it's just really going to round me up. But I do just want to say this one last thing. It's negligent to be inequitable when you're talking about AI systems, especially. And negligence in the healthcare world is a liability. It's not only a liability such that lives are lost, but physicians lose their license for being negligent, or if they'll lose their license if hospital systems are actually doing their job, right? That's what it is. But equity in AI, overall, it conveys accuracy. It should really inculcate representativeness of all people of all races, ages, gender identities, all of that. In that sense, we need more refined data. Not bigger data, but more refined data, more holistically representative data that we can trust, that is transparent, and that doesn't harm patients based on bias input.
So what more, and we've kind of touched on this already, but what more can policymakers do to help improve access? Dr. Izard, let's start with you. What more can we ask of policymakers to help us get better access in the state? Is it more targeted investments in the right things, or what are your thoughts?
Yeah, so I look at kind of addressing the needs, looking at like the 5 planes of humanity. So if you think about your physical self, your emotional self, your economic self, your societal self, and your spiritual self. And when we're looking at vulnerable or disenfranchised populations, really you need to look at it in a holistic way and try to assess what are the things that we can contribute to those those issues. As I mentioned, when people are in a bad situation, the instability creates dissociative behaviors, meaning that people don't always think linearly. It's like doing what's in their best interest. So it's important for us to be able to understand that if somebody's unstable, they're likely to make a decision that conflicts or contradicts their own faith, values, morals, character, and such. And without understanding those, that the person is more likely to do that the more unstable they are, it's hard for you to create a plan, so you have to incorporate them into it. So you're specifically creating, thinking of all these different components. So if someone's really sick, you would think, well, sick people go to the doctor, right? Well, are they feeling too sick to not come? We have patients all the time. How can you didn't come to your appointment? Oh, I was sick. It's like, hello, that's what we're here for, right? But you don't understand sometimes if someone is feeling sick and overwhelmed, it may be draining them. So being able to create your access to care plans, incorporating the things that you've gotten feedback from your patients regarding, right? And then thinking more comprehensively it's not just me as a family physician, but also I like to, when I work with a person, I'm thinking in terms of, all right, what I call the logos, well, Aristotle calls the logos, pathos, mythos, and the ethos, and thinking in terms of if the patient didn't accomplish their goal or objective that we worked on together, I'm refreshing myself to say, well, did the person have enough information, logic, or reason, or information, right? And if not, I have to make sure I provide that. Well, maybe the person didn't follow through because of pathos, which is emotional appeal. Maybe there's something emotionally that was holding the person back. You told them they had diabetes, but for them, diabetes is their grandmother that had an amputation and went blind. If you don't know that emotional fear is what's holding them back. If you think about the ethos, that's the credibility. You might give them all the perfect information, but you never truly assess the credibility with your patient, and that may be the one thing that's holding them back. And then the mythos is cultural beliefs, and sometimes you have to ask the person about kind of what's important in their decision making and what influences how you make decisions. All these things end up impacting on access to healthcare, and it's important as a provider or a caregiver to be able to listen to the person you're working with and then create specific plans and strategies that reflect from the community that you're working with.
Kirsten, I'm looking at Senator Miller in the front row. There's other legislators I know in the audience and aides of state legislators here today. If they came to you and said, what can we do to help improve access in the state of Wisconsin, what would be your answer to them?
I mean, simply Medicaid expansion to the 138%, I think is an easy answer. But I also think that access isn't just physical access, and I know a lot of work is happening at the federal level right now around addressing surprise billing, costs, drug costs, and there's a lot of controversy around the stabilization of the ACA versus Medicare for All. And I don't know if anyone here has actually read some of these Medicare for All bills, but and Dr. Altman sort of said this, that they're very broad. They're carve-outs for things that there probably shouldn't be carve-outs for example, the Indian Health Service. Well, if we're really going to give everyone equal access to care, we should give everyone equal access to care, and it should be equitable. And those plans are not. So I think we really need to, talking about stabilizing the ACA is not sexy or fun, but I really think that's where we need to focus a lot of our efforts, because I think we can make a lot of progress that way. And again, there's bills out there that federally that, individual bills that are trying to do some of that work. A lot of them haven't gotten traction, largely because of politics. But I think that's where we need to focus our efforts, is really thinking, small steps. How do we assure that the intent of the ACA is still in place? Because I'm not sure it entirely is, despite the fact that we have the lowest uninsured rate currently that we've had. I think that's the direction policymakers need to go. Look and think strategically about those policies, and small incremental change will go a long way.
Gwyn, from your research, what are some of the state policies that stick out in terms of having the most impact on increasing and improving access to care?
Well, I'll talk about two that are being implemented right now, and then kind of a broad overview. So one of them is a dental pilot program that's happening in Wisconsin right now. And under that pilot program, fees for Medicaid were increased in 4 counties, and so we're working right now to evaluate whether or not that actually increased either the number of providers or the number of actual services rendered. And so I think that kind of gets at your point that dental is not this small thing on the side, it's actually quite important. And then looping that back to kids, we know that dental pain or tooth pain is one of the main reasons children miss school, and so this could actually be quite important when we think about the lifelong trajectories of inequality. I don't know if this is, this hasn't exactly changed anything yet because it's still being implemented, but I'll talk about it because I think it's kind of neat and clever, is a waiver that's just being talked about right now, kind of related to the cliff between Medicaid and private insurance. So currently, if you're a childless adult in Wisconsin and you're between 50 and 100% of the poverty line, you might have to pay a premium. And so what the state is doing is kind of working to set these premiums up into health savings accounts so that when you leave Medicaid, this could go with you and potentially pay for your premiums on the marketplace. So I think that would kind of have a lot of sway, or at least, provide some cushioning for people who are leaving Medicaid. And then broadly, what I'd like to talk about or think about a little bit more is care coordination for individuals. And I think the state has a lot of programs going on related to care coordination right now. One of them is for foster children. It's called Care for Kids. And so really trying to nail down the fact that this is a potentially complex population, and so how do we help them out best? There's also a pilot that's being implemented in the near future in emergency rooms, and so here this is going to be looking at patients who are super utilizers, so they go into the ED room quite frequently, and so we're looking at how do we actually coordinate their care to try to set them up with a primary care provider. How do we set them up with housing? And so I think those kind of broad ideas that there are some services available that aren't just healthcare, so housing or food, for example. How do we set them up with anything that they might need? And I think those are 3 that I would touch on.
Yep, Dr. Izard.
And then, for legislators, couple quick things. Number 1 is looking at the LARCs, which are the long-acting reversible contraceptions. With the federally qualified health centers, it would be very helpful for us to be able to get the medications into the health centers, because the cost of the medicines are essentially cost prohibitive for us to be able to purchase them, because through Medicaid we will never get the cost of that reimbursed. So it becomes a barrier to access, as well as a risk of someone becoming pregnant or other. So if we can work to be able to get the LARCs to the health centers so that they can provide that to the patients. Number 2, looking at telemedicine. I know that's something that's being worked on right now, but looking at opportunities, sometimes the technology is advanced beyond what the legislation has, so there's just barriers there for us to be able to use it and be able to provide that to patients. And then another, which is a huge crisis that is looming that we need to be paying attention to, is looking at the National Health Service Corps loan repayment and looking at the HPSA score, which is the Health Profession Shortage Area scores that has happened nationally, and the impact that it is having in Wisconsin, and the potential of not being able to have providers who are eligible for loan repayment who want to work in underserved communities. That's going to be a major crisis issue. And then, so in addition to that piece with the HPSA area, is also looking at the limited number of healthcare providers that reflect the underserved communities. So not having enough Black and Latino physicians, Native American physicians, Hmong physicians, and other healthcare providers who will work in those communities. We know that that people from ethnic backgrounds disproportionately or higher proportion will go back and serve their communities. And the fact is we're not producing them like we should in Wisconsin, and that has to be addressed, because if other doctors who aren't able to come because of loan repayment, and then you don't even have doctors from your own community who even exist at all, there's going to be a major crisis.
Excellent. So Kirsten brought up the concept of Medicare for all. Since she brought it up, let's follow up on that a little bit. Mia, this is something that the AMA has somewhat softened its stance on, but it's something that the AMA has been opposed to. This is, as Drew mentioned in his keynote, the actual legislative debate about a Medicare for All program would look very different than what is being said on the campaign trail right now. But as of today, the potential front runner to be the Democratic nominee for president is running on a platform of Medicare for All. Can you just talk about the impact that you think that it could have, this general concept could have on access if this went forward?
Oh, you put me in a position here, Tim.
Just a general concept. I know this is we don't know the specifics, and it would be very different from what's being campaigned on.
You know, it's so interesting working for a space like AMA, because I have to tout the line, the AMA is not a supporter of Medicare for All. But I do want to raise up some points that you mentioned earlier, Kirsten, in terms of just as an actual policy, right? Yep. That can potentially be implemented. It will be damn difficult to do. It really would be, but I think the conversation is worth having in terms of what can a world look like where we won't have to have such a panel. I would love to be in a world where we will not have to have such a panel. Like, Bonnie, don't call me for to have this type of panel. I think I will. I know that's short, but it's. Drew mentioned, Dr. Altman talked about how in other nations they don't have the same level of tension around providing care for their citizens, and it's because the price point is very different, right? This really does come down to an economic conversation. What we haven't so much talked about is the politics of all of this, the optics of Medicare for All. It is a trigger word for a lot of people. And then if we were to just put that by itself, that makes it really unwieldy, right? But if we were to actually, as a nation, say, okay, what are we trying to accomplish by putting forth Medicare for all, Medicare for all, Medicare for all? Because the other thing is, too, the politics make it an election. That's essentially what it is. It's an election trigger word, right? But if we can just take that, move that veil back and talk about what are we trying to accomplish, which is ensuring that everyone has equal, and I'm using the word equal here, but I'm really meaning equitable opportunity for getting the care that they need and becoming their most, and living out their most optimal health and wellness. That's what Medicare for All is trying to accomplish. And for that, then I think that is what we need to strive for. But the vehicle needs some oil.
Well,
Tools and tires.
A muffler.
and then also, Medicare for All doesn't address or
The
doesn't
equity
close
bit.
the
No, it
health
does not.
disparities gap
No, it does not.
or health equity. So we still have that same issue. And we have already shown that even people who have commercial insurance with good incomes and all those other types of things still have health disparities.
Because of the cost issues as well. And the different bills do not really, it's not, okay, I'm gonna be quiet.
You were just getting going. Kirsten, you brought this up.
I'll speak to this as well.
Maybe expound on your
I will
points.
speak to it as well. And I should preface this by saying I worked for Congressman Ron Kind as his health policy advisor for the last year. So I read those bills. But I really think when we're talking about other nations, and Dr. Altman brought this up as well, is those that sort of, I don't want to say socialized medicine because it's a very charged term, but that idea around Medicare for all or health care for all came out of social movements decades ago. And we have moved beyond that. And again, it's come down to how much is it going to cost in our entire healthcare system. We pay doctors a lot of money. Hospital systems generate a lot of money. We pay insurers a lot of money. And how do you take this system that, frankly, we have created this monstrosity? How do we take it apart? And if we're really going to have a conversation about that, it go back to what are we trying to achieve? What are our values as a nation? And how do we come to a place where it's palatable for everyone?
That's right.
And I think that's a big.
If Medicare for All, if there was a bill today that said, with respect to inequitable health outcomes, this bill would wipe away the $1.24 trillion that are attributable to inequitable health outcomes, then I'm pretty sure the AMA will be like, where can we sign? But it's not the case.
Well, and if you think about the systems that we've built our healthcare system on, so CMS and Medicare and Medicaid, I would argue that CMS is not a high-functioning organization.
It's not a value. Value is not what's valued.
Exactly,
right?
exactly. So if we really want to talk about this, we have to take a big step back and look at our whole healthcare system and take it apart and identify what are our values and how are we going to pay for it. Yeah.
Great. So on that, we have time for audience questions. I think Peter's out in the audience with microphone.
Thank you. I'm Dr. Tim Harrington. I'm one of the people in the room who actually has spent a career in Wisconsin's health delivery system and continue to work with practices to improve their access to care. I bring a very different perspective than what we've heard so far, because in most parts of Wisconsin, as you pointed out, we have some of the highest percentages of insured patients. We have people who are insured just about every different way that you can get insured, and yet, independent of that, nobody can get health care. This is particularly a problem for patients with chronic diseases, the 30% of people who account for somewhere between 80 and 90% of the cost. Right here in Dane County, where we have more physicians than every place else in the United States except Rochester, Minnesota per capita. You can't get in to see a medical specialist for chronic disease for about anywhere from 3 months to a year after you're referred by your primary physician. And the same thing is happening in the Milwaukee area. Worse for people of color, but not limited to people of color. So I would just encourage everybody, and particularly you in the research area, to do the kind of thing that Catherine Kramer did, and that is actually go out and spend some time talking to the people that are providing health care, that are burning out, that are told by their administrators to go back in the office and work harder. And by the way, if you're burning out, at the same time, take more vacations and spend more time with your patients, because they're not happy that you don't have any time to spend with them. The thing that has disturbed me most recently is that the healthcare measures of our Wisconsin population have dropped like a rock over the last decade. The data I've seen is from 9th in the country among states to 29th, whereas in Iowa and Minnesota, right next door, with similar populations, they're sticking where they were at about 8th to 10th. So there's something happening in Wisconsin that's really toxic. And it starts, if we're going to talk about coverage and access, it's a problem with how our big health systems are functioning so that you can't get to see a doctor. And I'd like us to think more about that, because I don't care about what else you fix in terms of how you pay for it or whether we create equity. If people can't get in to the health system to get the care they need, we're going to continue to fail. Thanks for your time.
Okay. It's kind of more of a comment, but
it's
a good comment.
But I'm asking this as to what all of you there think about that problem, which is what the access thing that I thought we were going to talk about.
So I think that the overall question then was the lack of access in the state to specialists is a real issue throughout the state.
Well, I don't want to put words in your mouth, Dr. Izard, but I think you mentioned that with the loan repayment system, where that could potentially increase the number of providers, particularly serving underrepresented minorities. The other thing I'd mention is that this is specific for behavioral health, but just comparing states that expanded Medicaid to states that didn't, access to behavioral health improved quite dramatically in states that expanded. And in fact, it doesn't look like there was crowd out, meaning that if you had private insurance, you had longer wait times. It looks like suppliers were responding to this change. And so that, I think, is something maybe we think about as well.
Great. I think we had some questions up here in the front.
I had a question for Dr. Izard. About 50% of patients in community health centers throughout the country are Medicaid patients. And community health centers do a fantastic job in taking care of Medicaid patients, particularly with the drug discount program. This is very cost effective. The question is, can community health centers increase their care of Medicaid patients, and could that enhance Medicaid expansion in states who are dragging their feet? And I think one of the answers that you'll have is the shortage of primary care providers will inhibit expansion of community health centers right now. And I think you're aware of a group around the country where we've been advocating very strongly for neighborhood health centers directed by nurse practitioners because we have such a shortage of primary care physicians in the country right now, that if nurse practitioners could be trained with an additional year sometimes, particularly for geriatric care, they can be superb primary care providers and would allow community health centers to expand with these neighborhood centers.
Yeah, I would say over the last, I've been as chief medical officer or CEO for the past 14 years at my community health center. And over that time, there's been a significant change from more physicians in the clinical practice, primary care clinical practices, to more advanced practitioners, so midwives, nurses, and physician assistants. Your first question was, can community health centers, fairly qualified health centers, increase their Medicaid population? I think almost every FQAC that I know is actually specifically trying to do that. But really, when you look at the financial stability of the health center, financial stability is really dependent upon four things. Number one, productivity. Number two, the revenue cycle, which is from the point of the phone call to make sure you have all the correct information until that bill is paid. Number three, looking at your payer mix, which is the blend between Medicaid, Medicare, commercial, and uninsured. And the last component to financial stability is controlling expenses. And so every FQAC is constantly trying to work through, that formula to be able to say, how do we increase access? So at our organization, what we look at is demand, access, capacity, productivity. And I always tell everyone that we know there's a need in the community, but need doesn't always translate into demand. Just because someone needs healthcare doesn't mean that they want to come see you. So you have to be able to make sure that as an organization, you're addressing the barriers that may be preventing that need from becoming a demand for service. And then moving from demand, access, which we talked about. Capacity is the ability, how many can we actually take on the schedule to make sure that we don't burn out our healthcare providers and the rest of the team, and then being able to measure that productivity. So the challenge that we want to be able to take on more, but issues like we just talked about, having probably most of providers that start in an FQAC are coming out of their training programs, and it takes time for them to be able to build up, and you have to be able to have access to capital to be able to sustain that provider. The competition for the health systems over the last decade has been outrageous for driving up the costs, not just for providers, but even for medical assistants. And so being able to recruit and retain your team members, it is becoming significantly more costly.
The other thing I want to just insert with this, and this is especially for the students public policy students, right now, at least on the congressional level, we're right smack dab in the middle of appropriation season, right? And so when you're talking about really touching base and getting this message, I mean, you would know this, of course, but getting this message across to policymakers that our federally qualified health centers, our community health centers have to be, they are a stabilizing force within the communities, then the dollars have to follow it. Not just saying, because there's a difference between authorizing language that says we have to, protect our FQHCs and our community health centers, but it's a wholly different process when you're talking about appropriations right now. So the thing you all need to be doing right now between, what's today, the 2nd?
Yeah.
Put this in your calendar. I'm serious. Call your Be in Touch with Ron Kine. Make sure that you're touching base with Gwyn Moore and Pocan and who else? Baldwin, Senator Baldwin, and Senator Johnson. Call them. Send them letters, emails. Not just, and when I say them, I mean call their health staffers. You need to know their health staffers' names.
You can call and ask.
You absolutely can call and ask what their health staffer's name. Let's really quickly just do a phone call. And this is important because if these monies don't get to FQHCs, you're going to have the stability issues altogether. So let's ring.
Ron Kine's office.
Yes, hi. May I have the name of your health staffer?
Sure, it's Alex Eveland. Here's his number.
Thank you so much.
That easy.
That's all you
That's
need.
literally how it works.
Yeah, and make sure that you say, and it doesn't have to be a long tirade. Just say, I am so and so. I am a student at University of Wisconsin. I would really want to make sure that you have a line in your appropriations for supporting FQHCs. Unfortunately, gone are the days, fortunately or unfortunately, depending on where you fall, of earmarks. Policymakers aren't able to put aside monies for specific entities, but for entities that really do need protected status, you can certainly do that.
And in Wisconsin, another legislative policy that can be done is looking at physician assistants. In our state, physician assistants still have to operate underneath a physician, whereas nurse practitioners don't. And all of us who work with PAs and NPs know that they are very equal and comparable team members. It doesn't really make sense that old way of which we've done it, it really becomes more of a political issue. Big P and small p politics to those type of decisions. But that's something that can help. But even if we increase the number of PAs and MPs, typically in the federally qualified health centers, the advanced practitioners will see around 60% to 2/3 the number of patients. So you can't just swap out one doctor for one nurse practitioner because you will actually reduce the total amount of volume and therefore impact on access.
I was going to add to that. So really all mid-level providers, so allowing them to bill and practice to the highest level of their license is imperative. And there's a number, nurse anesthetists, dental hygienists, it's an issue around who can bill and who can't. And they all need to be able to provide services up to the highest level.
And this might be ironic for me to say, but put pressure on the AMA to support that.
Yes,
as well.
yes.
Yep, and I guess I've been getting the notice that's the end. So thank you guys so much. Thanks to our panel for a wonderful, wide-ranging discussion. Thank you all for coming. Enjoy the rest of the day.
So everyone, real quick, lunch is going to be in the terrace, that big room just past the registration tables with the windows looking out onto the lake.